Good morning to each of you. I see some of our legislators here. Welcome. I thought it'd be appropriate if I made a little bit more extensive comments on the possible impacts of the current Senate bill on Arkansas, and to be more clear on what changes I see that they need to make. I first want to compliment our Senator Bozeman and Senator Cotton and the rest of our federal delegation for the dialogue that they've had, how they're listening. I've talked to them numerous times in the last week. We'll continue that discussion. And I know that they are taking the concerns that have been expressed to the leadership and making that part of the discussions in Washington. We will continue that dialogue. Most importantly, it is important to recognize that what we have right now under the Affordable Care Act is not a safe path for our future in Arkansas or in America. It is too expensive. It does not give the states sufficient flexibility. It puts the state at risk in terms of cost as well as the federal budget. And so the current path is not sustainable. We have to have change. They're working diligently to have that change and to do it in a way that works for America. I want them to listen to the governors. We have communicated regularly with the Senate leadership and the House leadership over the last 3 or 4 months. We'll continue to do so. And so change has to be a part of the equation for the future. But the Senate bill is changing right now. People ask me, well, do you support the Senate bill or do you not support the Senate bill? That's really not a fair question because it's changing day by day. And we all know that there will be more changes that will be made in the coming weeks before the final vote is taken. And so I just want to make comments as to what the current draft is and what changes we are advocating for the Senate bill and as Congress continues to consider this. As it stands now on the Senate bill, it does some good things. It reduces costs, it cuts the deficit, and provides more options for the states. And so it is progress. It moves us in a more positive direction. It provides less federal control over the commercial insurance market, and it provides more regulatory flexibility to the states. These are all good things. These are things that we have advocated for and we're delighted are included in the current version. But the big problem is that the Senate bill does continue to shift costs to the state, and that leaves states like Arkansas with few choices. Arkansas, as you know, prior to my election as governor, made a decision to expand coverage of the Medicaid population, and that expansion was based upon a federal commitment, but the Senate bill reduces that federal commitment from the 90% level of federal participation down to the traditional Medicaid reimbursement rate. That is a dramatic shift of federal participation in the Medicaid program. And so when the reimbursement rate is reduced, then the state has got difficult choices to face. It either has to reduce the expanded Medicaid coverage, or we have to cut costs in the traditional Medicaid program, and that includes children, elderly, and people with disabilities, or it could be a combination of cuts to both, or we can increase taxes. Now, with the legislators standing here looking over my shoulder, I want to assure them we are not raising taxes. So the result is that the Medicaid coverage will be reduced if the current Senate version was adopted. And let me just elaborate for a second on that. If in 2020 the expanded population, expanded Medicaid coverage is reduced by the federal participation from 90% down to 67%, the state of Arkansas could not absorb that additional investment that would be required to maintain the coverage for 300,000 Arkansans. And so we would have to make dramatic changes based upon that reduced federal participation. Now, it is clear that we have to achieve substantial savings both in the federal government marketplace but also in the state by reducing the rate of growth in Medicaid spending, and Arkansas is fully committed to doing that, as well as having innovative approaches for reviewing Medicaid, reforming Medicaid. Here in Arkansas, we have already led the way in reform and savings. We have reduced, through the waiver that will be requested, Medicaid eligibility from 138% of the federal poverty level to 100%. We have put in mandatory work requirements on able-bodied adults. We have engaged in transformation initiatives that result in savings over 5 years of $835 million. This is reform efforts that we are accomplishing in Arkansas that benefits the savings for our state in terms of general revenue, but it also reduces the cost of the federal government. And so this is our view, is that we can work together to reduce the growth in spending on Medicaid through reform efforts that we're already accomplishing in this state. And that those savings are being accomplished in partnership with the provider community, with the legislature, in a team effort, and we're leading the way in reform and in creating savings. And so with that background, with the challenge that we face with the current version of the Senate bill, we're recommending changes to the Senate bill. We're not saying do nothing. We're saying we need to do better, and we need to have a better result from the debate in Washington. And so under the Senate proposal, the age, blind, and disabled populations, which is the part of the traditional Medicaid population, they are shifted to a per capita cap. This is traditional Medicaid, as I mentioned, that will ultimately reduce the financial commitment to the states from the federal government. Whenever they go to a per capita cap in a population that has historically had high expense categories, that will represent a cost shift to the state by their movement to a per capita cap, and that is of the traditional Medicaid population. And so our suggestion is that that traditional Medicaid, that this category needs to be exempted from the per capita cap. And that is one of the traditional Medicaid categories. Otherwise, it represents a cost shift to the states. The second recommendation is that the block grant option that is provided, it needs to be extended to include the expansion population. Now let me underscore that for a second. We are right now working to create savings within the expanded population, which is up to 138% of the federal poverty level. If our waiver goes through, it'll be reduced down to 100% of the federal poverty level. But under the current Senate version, the block grant option does not include the expansion population. And so that again puts us in a difficult position of being unable to manage that expansion population to create the savings that's needed and to maintain the coverage that's currently in place. And so we would urge the Senate to include the expansion population in that block grant option. If we do this, then the states can assume risk, create savings, and assure continued coverage for the working poor. The third recommendation is that we redesign the tax credit subsidies that stabilize the individual marketplace. And so if we move from 138% of the federal poverty level down to 100% or make some other judgment there, then those will be able to move on to the individual marketplace and have insurance coverage there. But if that subsidy is not sufficient in the marketplace, then that individual who loses coverage under the Medicaid program will make the decision, I can't afford it. And it will ultimately wind up with lost coverage. And so you have to be able to give them an incentive to move up that economic ladder, to move off of Medicaid, and to have that incentive, you have to have sufficient subsidies as tax credits on the individual marketplace to make that work. And that needs to be redone in the Senate bill. And then fourthly, we would ask them to give the states greater control over the Medicaid program under the per capita option. And so if you take that, that is assuming a risk to the state because there's a cap on what the participation will be by the federal government. You've got to give us the flexibility to manage the program and create the savings and deliver the services. So you've got to have that kind of flexibility. We'd ask for additional tools that the state can use. And so let me reemphasize that the Senate is moving in the right direction. The status quo is not acceptable, but there has to be significant changes in the current draft in order to give the states like Arkansas options for our future that we can continue the coverage and not have a $500 million per year gap in our economy. Let me finally say that there's been a question as to when, if the legislation is adopted in Washington that rolls back the federal participation, the federal match rate, what will that do to trigger the end of Arkansas Works? And we have received that we'll distribute to you an opinion from the legal counsel at DHS that indicates that Arkansas Works will not end upon passage of a law that reduces the federal Medicaid match at some point in the future. The wind down would not be triggered until an actual reduction occurs. So that's based upon legal counsel at DHS. That is my view, and that would be the position of the administration. And so I hope that takes a little bit of pressure off of the immediate worries because one thing the Senate is doing very well, and that is giving a very long glide path that allows us to continue to look and plan and adjust to whatever is the final outcome on the congressional action that they are considering at the present time. So with that, I'd be happy to turn this open to any questions.
Governor, I know you say it's an unfair question, but without these changes, do you oppose the Senate bill as is if it doesn't have these changes in it?
My duty is to be an informed governor and to inform our federal delegation as to the impact on this state. I'm being very clear as to the impact that it would have on the state of Arkansas, on our health care coverage, and what it would do to Arkansas Works, which we have worked hard for, I have fought hard for, the legislature has fought hard for. And so we want to educate them on the impact of it and then be forward-leaning and say these are specific suggestions that would help remedy the bill and would help us in Arkansas to meet the savings goal, but also to meet the goal of continued coverage. So I don't think it's incumbent upon me, because I'm never going to be able to see what that final draft is. I know I've been in Congress, and I know how it works, and there's changes up until the last minute. So I am giving advice and counsel as to the impact on Arkansas. I'll leave the final vote up to the delegation.
Given that the bill did arrive at the draft, at least in this stage, in this form, do you feel like Senator Cotton and Bozeman are listening to you if this is part of the plan?
Oh, I think they're absolutely listening to him. I've talked to them. We've worked very closely together on this, and I very much appreciate their conveying our concerns and suggestions to their Senate colleagues. In fact, each one of the recommendations that I made today for changes in the bill have been conveyed previously to our Senate delegation, and I know that they're looking at that and conveying that to their colleagues.
Do you know if Senator Cotton agrees with these changes?
You'll have to speak to him.
Functionally, the per capita cap, what does that actually look like in Arkansas, especially when you're talking about the traditional Medicaid population? For folks who are on that, what would that mean with practically?
Well, if you take there are a lot of different ways to construct a per capita cap, but that means you take the current Medicaid dollars for a traditional population and you divide it by the number, and that gives you the amount that's being spent per capita. That's okay for 1 year, but the problem is this is a high-need population, the aged, the disabled, and so the medical costs go up higher than the traditional rate of inflation, and so you're putting the states in a bind with a per capita rate that would not give us the amount that is needed for the coverage of this population with the medical rate of inflation. And so that's the concern there. And so we would have to adjust down services. We would have to create savings elsewhere, raise taxes, or put more dollars from general revenue in there. And that's a tight squeeze for a state to make.
But the population would still be served, not served in the way that they're currently served.
That's correct. Absolutely, it is just a cost shift to the states. It doesn't mean the states are not going to assume that responsibility, provide the proper care, do everything they can to make sure those services are met. It's just a different way of funding it, but it's not a sufficient way of funding it, and therefore the state would have to absorb more of the cost.
When you use the term $500 million gap, what were you referring to?
Well, if you look at how much is being spent through federal dollars in our economy through their Medicaid participation, our estimates are that with the action that would be taken and the reduced participation, that's like pulling $500 million out of our healthcare system in Arkansas.
Do you have an estimate on, because there's been all sorts of numbers flying around, what it would cost to unwind Arkansas Works? I mean,
No.
because you'd have to shift populations back to traditional Medicaid program, fill in the holes of uncompensated care that used to be. Have you estimated what that would be?
What the process would be?
What the cost would be?
No, we have not estimated that. We're concentrating on, first of all, the reform efforts and our transformation efforts to make sure it's a strong program for the future. That's what our focus is. And so in terms of winding down something, one, I hope we don't get to that point. And secondly, if we do, we'd have to estimate the cost at that time.
If this Senate bill version like this passes, what Medicaid programs would the state cut first in terms of the optional Medicaid programs that the state currently funds?
You mean if the Senate bill passed? I would not speculate on that. If you look at, and I made it clear, the first challenge is the expanded Medicaid program. Those that are making up to currently 138% of the federal poverty level. These are people who are working, have some income, but they can't afford health insurance. Right now, we're covering that. But if that match is reduced from 90%, which was the original commitment, down to the traditional match rate, which is the current plan, then there would be no choice but to end the expansion program unless the legislature deemed it necessary to come up with hundreds and hundreds of millions of dollars in order to fund that program. And I think that would be doubtful.
The Senate bill reduces spending on Medicaid and also cuts taxes at the federal level on investment income and I believe on insurance. So, I mean, you're proposing essentially preserving some of the spending that the Senate bill proposes to do away with. Would you also then prefer to see those taxes stay in place, and how would you pay for this?
According to the CBO, the savings under the Senate plan really exceeds the savings under the House bill. I think the debate will be is whether that in order to continue the federal partnership with the states, that savings should be reduced. So I'm not going to get into all the tax implications of the bill. I just wanted to speak to the burden that would be placed on the state in terms of this cost shift.
You said obviously you said in the continent and Bozeman. Have you talked to your staff and lawmakers here at the state level about these changes and what are the state's priorities if some of these changes take place?
I really think it's totally premature to look into the future and say, if this happens at the federal level, this is what we need to do, partly because there's such a long glide path, 2020, before much of this would come into impact in terms of the cost shift. And so we have to wait and see what the final outcome is at the federal level, and then we start making decisions here in Arkansas. There's plenty of time to do that, and I got a little criticism for it the other day, but I think it's still the appropriate language. My purpose today is not to create concern. My purpose is to be responsive to inquiries and to educate and to increase awareness on what this means for Arkansas, but this is not to create alarm.
You mentioned that you probably won't ever see a final draft, and it just anecdotally, and I'm sure a lot of the reporters can attest to this, I've been getting a lot of phone calls from viewers who are concerned because nobody's talking to them and telling them, what this could practically mean. They don't understand necessarily the debate that's going on at a national level, but they're worried about whether or not they or mom can go into a nursing home, or if the home health care is going to be the first thing that's cut. Is it something that you would possibly advocate for more town halls prior to an actual vote on this, so that people of Arkansas can be educated prior to the final draft before anything's really passed?
That's up to the federal delegation. I think they're very responsive. I think they have heard from all of the groups, from the Healthcare Association to average citizens. Everyone is communicating with them. I know they're hearing plenty. That interaction needs to be left with them. Your point is well taken that, for the average citizen that is concerned about their mom, that's dependent upon Medicaid, that's in the nursing home, my comment to them is, please be assured that Arkansas is going to stand with you, and we're not going to allow those that are dependent upon the traditional Medicaid to suffer or to have a significant cutback in services. We're going to stand with them, and they need to have that confidence, and it's really important that they have that security. The biggest challenge and what's in jeopardy to the greatest extent is, first of all, the expanded population, which those are those that are able to work, those that are trying to move up the economic ladder. That's where the greatest uncertainty will be, but it would not be on those that are really dependent upon the traditional Medicaid services. And that's the difference, and we need to provide that assurance. And there's a lot of worry out there, I understand that, but that's just part of the debate that we have anytime a major piece of legislation is considered. A lot of change, and you have to just wait and have confidence that we're going to do the right thing with our Arkansas residents.
The CBO has said that it believes millions of people would not choose to get insurance on the exchange, and one big reason is that the deductibles can be so much higher that it might not be worth it to get the insurance. Do you have a concern about that?
Yes. I mean, that's in essence what I was speaking of, is that if you move people to the exchange, but you don't provide sufficient subsidies, then, as you said, their cost share or their premium is going to be too high for them to afford it whenever they might be making 50% of the federal poverty level. Because whenever you look at if there's a massive cost shift and we actually have to end the Medicaid expansion, then these people, their only option is the subsidies on the exchange, and if that's insufficient, they will just not be able to afford it. And so that's the reason for the CBO saying there's going to be many people that will choose not to be covered because of an affordability issue, and the result is uninsured. And these are tough issues. What I advocate is we can share with the federal government to create savings. We've done $835 million in savings. We can continue to cut the cost curve in Medicaid growth, share the savings with the federal government, but let's maintain a sufficient coverage so that we're not going to be ending the coverage for 300,000 Arkansans.
In the recommendations, it doesn't include maintaining the enhanced match for the expanded population. So do you think the enhanced match should be maintained, or if not, then how should we handle the expanded population?
That would be put them into a block grant. That's an option that we want in the legislation that would extend that block grant coverage to the expanded population. Well, it would be with a joint participation. If you look back at some of the letters that we've submitted to the federal government, it has to have a maintenance of effort from the state. So our commitment would be there, and then we would negotiate exactly the amount of federal participation based upon that, but it would be similar to what we are doing now in the enhanced matched, but it would protect the federal government from escalating costs in the future, because it'd be a block grant that we're assuming the risk for on the growth of that, and we can manage that. So under that proposal, it amounts in savings for Arkansas, but amounts in savings for the federal government.
So it'd be a block grant that's based on the enhanced, the 90% level, and then it would be, that's where the baseline would be set for the block grant.
I think that's into the weeds a little bit more. It needs to have a maintenance of effort by the federal government and the state government that's similar to what we have right now. The exact percent, I think, can be negotiated, but it can't drop down to the traditional match rate.
Why is it better for the state to assume the risk instead of the federal government?
Well, it's better for the federal government for us to assume the risk because it limits their cost exposure. Why is it? And we don't mind assuming the risk at the state level if we have the flexibility and the tools that we need to manage the cost. And we can do that, and we've proven that we can do that. We can adjust and react to market conditions much quicker than the federal government can in terms of managing our health care expenses in Arkansas.
Governor, this legislation would also affect school districts, and I think that's something that Arkansans don't realize, is that a lot of the dollars, there's like more than $30 million that goes to the state of Arkansas school districts just so kids can, have access to nursing, speech pathologists, things like that while they're in school. How concerned are you that these kind of services could go away? I know school districts are already maybe looking at having to lay off people.
Well, again, it's part of that $500 million impact every year in the economy of Arkansas. It's a lot of different ways that it touches, whether it's the schools in the services they provide, or whether it is in traditional Medicaid or the expanded Medicaid population. So it's something that they need to voice and express their concerns, as I know that they're doing.
Can you walk through, just to make sure I understand, the $500 million figure, is that the annual impact under the Senate bill as is now, and how what's the breakdown between state and federal on that?
We'll follow up with you on that, give you more specifics on that.
I guess is that impact under the bill as it is now? I was trying to figure out the number you're throwing out what that takes.
That's based upon what the cutbacks would be over time to the state of Arkansas in terms of economy. But let me get you something afterwards on that.
There are traditional Medicaid populations aside from the age blind and disabled, such as our kids, that potentially could be impacted by a per capita cap or block grants for Medicaid moving forward. Why is that not a part of the proposal? Why is your, as far as concern about shifting to a per capita cap limited just to these populations?
Well, but who are you concerned about?
Well, I'm saying, thinking about our kids, for example, and non-disabled children. It's my understanding that under the Senate proposal, if the per capita cap is put in place and it's no longer an open entitlement, then over the long run, the state can see a hit to that revenue coming from the government, federal government as well.
Well, we want to exclude, of course, the most high expense categories of coverage. In terms of that coverage, I think that's something that can be managed, and I think you can manage a block grant or a per capita funding model and manage it well, as long as you're not into an area that is the most explosive. For example, many children are healthy, and so if you have a per capita amount that includes children, that's easier to manage versus the elderly population with very unexpected illnesses and expenses that are hard for a state to manage. I think we've exhausted this topic for this morning, but thank you for giving me this opportunity to elaborate on my views on this, and look forward to following up on a few items. Thank you.